Just Humor Me by Stacey A. Hubay, MD, MHSc. Most of the people who read this journal will know the feeling. You are lurking at the back of a school function, or perhaps you're making small talk with your dental hygienist when the dreaded question comes up. So what kind of work do you do? I usually give a vague answer along the lines of, I work at the hospital, to avoid the more specific response, which is that I am an oncologist. I have found this information to be a surefire conversational grenade, which typically elicits some sort of variation on, wow, that must be so depressing. Although one time I did get the response, great, I'm a lawyer and a hypochondriac. Mind if I ask you some questions? After I recently dodged the question yet again, I found myself wondering, why am I so reticent about telling people what I do? While discussing work with strangers in our hard-earned free time is something many people wish to avoid, I think for me, a significant motive for this urge to hide is that I do not actually find the cancer clinic to be an overwhelmingly depressing place. Admitting this to others who are not engaged in this work can lead to, at the very least, bafflement, and at worst, offense to those who believe that laughing while looking after cancer patients is a sign of callousness. I am an oncologist who laughs in my clinic every day. Of course, the oncology clinic is sometimes a bleak place to work. Cancer has earned its reputation as a fearsome foe, and the patients I see in my clinic are often paying a heavy toll, both physically and emotionally. Many are grappling with their own mortality, and even those with potentially curable cancers face months of challenging treatment and the torture of uncertainty. Yet somehow, perhaps inevitably, the cancer clinic is not just a place of sadness and tears, but also a place of hope and laughter. Although most of us recognize humor and use it to varying degrees, few of us consider it as an academic subject. A few lucky souls in academia have taken on the task of developing theories of humor which attempt to explain what humor is, what purpose it has, and what social function it serves. Although there are almost as many theories of humor as there are aspiring comedians, most explanations fall into one of three categories: relief theory, superiority theory, and incongruous juxtaposition theory. Relief theory holds that people laugh to relieve psychological tension caused by fear or nervousness. I suspect this is the most common type of humor seen in a cancer clinic, given the weight of fear and nervousness in such a fraught environment. The second category, people being what we are, asserts that sometimes we laugh out of a feeling of superiority to others. It goes without saying that this sort of humor has no place in the clinician-patient interaction. Finally, we laugh at absurdity, or as Kant put it, at the sudden transformation of a strained expectation into nothing. This last category is also surprisingly fruitful in the oncology setting. Laughter in the cancer clinic is still to some extent considered taboo. Near the start of my oncology training, I remember laughing until my stomach hurt with my attending staff in the clinic workspace between seeing patients. What we were laughing about escapes me now, but what I do clearly recall is an administrator in a buttoned-up suit striding over to us in high dudgeon. "Don't you people realize this is a cancer clinic?" she admonished us. "This is not a place for laughter," she added before striding off, no doubt to a management meeting or some other place where the policy on laughter is more liberal. At this point, my attending and I looked at each other for a beat and then burst into helpless gales of laughter. We do not tend to think all that much about why we are laughing at something, but looking back now, I think at least part of the reason was the absurdity of a person so unfamiliar with the culture of the cancer clinic, presuming that physicians and nurses somehow park their sense of humor when they arrive at work and turn into a herd of gloomy Eeyores. We oncologists are starting to come clean about the fact that we laugh in the clinic, and there is now a modest amount of work in the medical literature addressing the use of humor in oncology. One survey of patients undergoing radiotherapy in Ottawa found that a stunning 86% of patients felt that laughter was somewhat or very important to their care, whereas 79% felt that humor decreased their level of anxiety about their diagnosis. If we had a drug that decreased anxiety levels in 79% of patients, had minimal to no side effects when used correctly, and cost the healthcare system $0, should not we be using it? Sometimes it is the patient or their family member who introduces an element of humor into an interaction, as on one occasion when my patient was filling out a pain survey, which included a diagram of the body on which he was asked to circle any areas where he was having pain. As his wife ran through a detailed list of his bowel habits over the past few days, the patient circled the gluteal area on the diagram he was holding, pointed to his wife, and said, "I've been suffering from a pain in my ass, doctor." His wife looked at him pointedly for a moment before the two of them started laughing, and I joined in. Sometimes a patient's use of humor serves to level the playing field. Patients with cancer are vulnerable, and the physician is an authority figure, meting out judgments from on high. My patient from a few years ago was having none of that. I met him when he was referred to me with widely metastatic lung cancer, a diagnosis typically associated with a dismal prognosis. The patient, however, was not buying into any of the usual gloom and doom that is customary for these interactions. As his daughter translated the information I was providing, he tilted his chin down, fixed his gaze on me, and proceeded to smile at me in a disarmingly friendly way while simultaneously waggling his generous eyebrows up and down throughout the interview. Over the course of 45 minutes, I became increasingly disconcerted by his behavior until eventually I was unable to finish a sentence without sputtering with laughter. If you think you would have done better, then you have clearly never been on the losing end of a staring contest. By the end of the interview, all three of us had happily abandoned any hope of behaving with more decorum. Laughter and the use of humor require a certain letting down of one's guard, and the fact that all three of us were able to laugh together in this interview took me down from any pedestal onto which I might have inadvertently clambered. One study from the Netherlands noted that patients used humor to broach difficult topics and downplay challenges they faced, and concluded that hierarchy as usually experienced between healthcare professionals and patients' relatives seemed to disappear when using laughter. If applied appropriately, adding shared laughter may help optimize shared decision-making. Although it could be a coincidence, it is worth noting that several years after meeting this patient, I discharged him from my practice because he had somehow been cured of lung cancer. Perhaps laughter really is the best medicine. On other occasions, it might be the physician who takes the plunge and uses humor during a clinical encounter. The same Dutch study by Bueting et al. Noted that 97% of all specialists used humor in their interactions, and all reported laughing during consultations at least occasionally. One of my colleagues, a generally serious sort whose smiles in clinic are as rare as a total eclipse, albeit not as predictable, managed to win over his patient with a rare outburst of humor. During their first meeting, the patient listed off the numerous ailments he had experienced in the past, including his fourth bout with cancer, which had prompted this appointment. As he finished reciting his epic medical history, my colleague looked at him somberly over the rim of his glasses for a moment and asked, "Sir, I must ask, who on earth did you piss off?" The patient was so tickled by this interaction that he recounted it to me when I saw him a few weeks later while filling in for my colleague. Although humor is a powerful tool in the clinic, it is of course not something that comes naturally to all of us. Attempts at humor by a clinician at the wrong time or with the wrong patient do not just fall flat, but can even be damaging to the physician-patient relationship. Even if a physician uses humor with the best of intentions, there is always the possibility that they will be perceived by the patient as making light of their situation. As Proyer and Rodden point out, tact is essential, and humor and laughter are not always enjoyable to all people. Or, to borrow a phrase frequently used by one of my patients, about as welcome as a fart in a spacesuit. So-called gelatophobes have a heightened fear of being laughed at, and with them, humor and especially laughter must be wielded with great care, if at all. All I can say in response to the legitimate concern about the use of humor being misconstrued is that, as with any other powerful tool physicians learn to use, one improves with time. As far as PubMed knows, there are no courses in medical faculties devoted to the fine art of the pun or the knock-knock joke. But even if we physicians cannot all reliably be funny on command, perhaps there is something to be said for occasionally being a little less self-serious. One might also be mindful of patients with whom one is not directly interacting. To a patient who has just received bad news, overhearing the sound of laughter in the clinic corridor has the potential to come across as insensitive. Moments of levity are therefore best confined to a private space, such as the examination room, in which physicians and patients can indulge in anything from a giggle to a guffaw without running the risk of distressing others. The final reason I submit in support of laughing in a cancer clinic is admittedly a selfish one. While humor has been shown to have the potential to reduce burnout, the real reason I laugh with patients in my clinic is because it brings me joy. The people at parties who think my job must be depressing are not entirely wrong. I have noticed that when I have a positive interaction with a patient based on humor or laugh with a colleague about something during a meeting, I feel better. Surprise! As it turns out, this is not just an anecdotal observation. In 2022, a study was published whose title was Adaptive and Maladaptive Humor Styles Are Closely Associated with Burnout and Professional Fulfillment in Members of the Society of Gynecologic Oncology. The SGO has not, to my knowledge, been widely recognized up to this point for their sense of humor, but I have a feeling that might change. Humor is an essential part of the way I approach many situations. And given that I spend the majority of my waking hours at work, it is neither possible nor, I would argue, desirable for me to leave that part of myself at the entrance to the cancer center. So, to the administrator who admonished my mentor and me to cease and desist laughing in the cancer clinic, I respectfully decline. My patients, my colleagues, and I will continue to laugh together at any opportunity we get. Joy in one's work is the ultimate defense against burnout. And I, for one, intend to take full advantage of it.
Hello and welcome to JCO's Cancer Stories, The Art of Oncology, which features essays and personal reflections from authors exploring their experience in the field of oncology. I'm your host, Dr. Lydia Shapira, Professor of Medicine at Stanford University. Today, we're joined by Dr. Stacey Hubay, medical oncologist at the Grand River Regional Cancer Center. In this episode, we will be discussing her Art of Oncology article, Just Humor Me. Our guest disclosures will be linked in the transcript. Stacey, welcome to our podcast and thank you for joining us.
Thank you for having me. It's a pleasure to be here.
It is our pleasure. So let's start by chatting a little bit about what humor means to you and what led you to write this piece and share it with your colleagues.
I didn't realize how important humor was to me until recently. I just finished a master's in bioethics, which was 20 years in the making. And this was the first time I'd been writing anything that wasn't a case report for many, many years. And there was actually specifically a course called Writing in Bioethics. And this was the first thing that came to my mind. And I realized sort of how much humor there is in my day-to-day work life, which, because none of the other people in this bioethics class of 10 or 14 people were working in oncology, they were surprised. So I thought it would be interesting to write about that. And then when I started thinking about it, I realized sort of how integral it is to kind of most of, I guess, not just my practice life, but the way I deal with life. And then I could see a thread kind of going back all the way to the beginning of my practice in oncology. And I'm like, I should write about this. And I don't think it's unique to me either. I think it's probably many of us in this field.
It is. So let's talk a little bit about humor in the practice of such a serious specialty as we tend to think, or people tend to think of as in oncology. You talk about humor also connecting you with joy in practice. Can you tell us a little bit more about that?
I'm just as surprised probably as anybody, at least when I first went into this field, which is now more than 20 years ago, how much happiness I found in the field. I meant what I said in the beginning of this essay. When I run into people or strangers, you're getting your hair cut or you're, at your kids' volleyball practice, and people always say, oh, so what do you do? And I always say, I'm in healthcare. And if they start drilling down, eventually I have to admit what I do. And I say, I'm an oncologist. And immediately the long faces and people say, that must be so terrible. And I'm like, well, it can be, but it's not as bad as you might think. And they're like, oh, it must be very difficult. And I know that avenue of conversation is closed. Once or twice, I think I did try saying, you know what? I have a surprising amount of fun in my clinic with my patients. And they were aghast, I think is the word I would use. And it made me realize sort of what a taboo it is for many people, including maybe some of us in the field, to admit that we sometimes enjoy ourselves with our patients in our clinics.
So let's talk about that. Let's talk about joy and then from there to laugh. I think the reason why laughter seems sort of stranger than joy is laughter assumes that we see some levity, humor, and some people would say there's really nothing funny about having humor, and yet you seem to see it and find it and share it with your patients. So take us into your exam rooms and tell us a little bit more about your process.
It's funny when I think about the humor in my clinics, I don't see myself as the one who's necessarily sort of starting it, although maybe sometimes I do. I think perhaps it's just I'm more open to it. And I think it's frequently the patients who bring it in with them. Obviously, as we know, patients in the oncology clinic, they're often very nervous. It's a very anxious time for them. And we are in a position of power compared to our patients. They're very vulnerable. And so sometimes the patient makes a joke. Sometimes I wonder if it's a way of sort of testing if that kind of relation will work with you. They're kind of testing you to see if you will respond to that. And it's also a way of them relieving their own anxiety, because one of the theories about humor is just a way of our alleviating tension. It makes sense in oncology, a place where humor would be welcome, because it's one of the most tense places, I think, in medical practice. Although I'm not sure it's present in other places like the ICU. So the patient often brings it in, and then you respond to it. And, if you're on the same wavelength, it sort of immediately establishes this kind of trust between you and the patient. It's not something you can do with everybody. Sometimes some people will not be open to that at any time. And some patients, you have to get to know them quite a bit before that starts to come into the mix. But I find with most people, if you follow them for long enough and you have a good working therapeutic relationship with them, just like you would the people you like, your friends, your family, that comes into the relationship almost unavoidably. And I used to think, I'm not supposed to do that. When I first came into practice, I'm a serious oncologist, which I am, and I can be a serious oncologist. And I also just didn't have the bandwidth for it, I think. I was so kind of focused on, I have to know what I'm doing early in my practice. I didn't have the mental energy to devote to that. And then as that part became easier, I became kind of more open, I think, to that coming into the interactions with my patients. And over time, I started realizing that was probably what I enjoyed the most about my working day. At the end of the day, I'd come home and tell stories, and my kids would be like, "It sounds like you have fun at work." And I go, I really do. Surprisingly, I do.
That's so very cool. I think there's so much wisdom in what you just told us, which is that at the beginning, especially when in the first few years of your practice, you really are so focused on being clinically competent that you may be just very nervous about trying anything. And then as you relax, you actually say in your essay that for some people, this may bring relief and may level the playing field. So if there is an opportunity and you're loose enough to find it, you may be able to keep that conversation going. It made me wonder, I don't know if you've had any experience yourself as a patient or accompanying a family member as a caregiver to a medical visit. Have you used humor when you are the patient or when you're accompanying the patient?
That's an interesting question. I haven't been a patient apart with my, routine family medicine visits for quite a long time. But when I was much younger, as a teenager, I did have that experience. And I was maybe 15 or 16. I had some parathyroid issue. And I remember I was seeing these specialists in Toronto, and they were very serious people. And I remember thinking, if I want to become a physician, because it was at the back of my mind at the time, I'm going to be a lot more fun than these people. I'm going to enjoy myself a lot more. And, little did I realize how difficult that actually was. So at the time, but I found them kind of very serious and a little bit intimidating, as a 15-year-old kid. I hadn't reflected on it before. I'm not sure if that's something that I'm deliberately kind of pushing back against. I think now if I see a physician as a patient, I probably am much more willing to bring that in if the physician is open to it. But you can usually tell. Many physicians, you meet them and you're like, you're not going to even try that kind of thing. And but if they're open to it, I think it would bring me much more fun as a patient as well.
Yeah. Do you teach your students or trainees or members of your team to use humor?
That's a very interesting question. How do you do that? So when I mentioned I just finished this master's of bioethics, and one of the excellent courses in it was how to teach bioethics, which really was a course about how to teach anything. And most of us who are in medicine, we've spent a lot of time teaching without being taught how to teach. In my own practice, the teaching we mostly use one-on-one with people coming into our clinics and seeing patients with us. And I think mostly, so some of it's through observation. I will say to people who work with me that we all have to find our own style. It's important, no matter what your style is, to try and connect with patients, because you're trying to create a therapeutic alliance. You're on the same side. The way that works for me is you don't laugh with people you don't trust. When you're trying to kind of make a plan with people in these difficult situations, I think if you've already formed this alliance where they realize you're with them, they're more likely to believe you and trust your recommendations. I tell trainees, I'd say, this is my way of doing it. And if it works for you, that's wonderful. But I can see that for some people, it's difficult. Although even the most serious clinicians, one of my very good friends and colleagues who I mentioned in my essay, and I talked about how He doesn't make a lot of jokes with his patients, which is perfectly reasonable. But the occasional time he does, the patients were so struck by it because they knew him as such a serious person. They bring it up. Like, remember that time my doctor said this, and they thought it was a wonderful thing. So it's difficult to teach. It's just, how would the Marx Brothers teach someone else to be the Marx Brothers? It can't be done. Only the Marx Brothers are the Marx Brothers. Not that I'm comparing myself to the Marx Brothers by any means, but I think you find your own style. Maybe what I'd like to show trainees who come through with me is that it's okay to enjoy the patients, even in a very serious discussion.
Yeah, I would almost say that it speaks to the fact that you're very comfortable with your clinical persona and that you can allow yourself to be totally human with them. And if human means that you can both sort of align around seeing some humor or cracking a joke, that is perfectly fine. I have a question for you, and that is that a lot of my patients in my practice, and maybe in some of our other listeners, come from completely different cultural backgrounds, and many don't speak the same language as I do. So for me, thinking about humor in those situations is impossible, just because I just don't even know what we can both accept as funny, and I don't want to be misunderstood. Tell me a little bit about how to think of humor in those situations.
That's a good point you make. It makes me think about how when I read Shakespeare's plays, we always think his tragedies are fantastic. And when I read his comedies, I'm like, this isn't very funny. Or if even when you watch sort of silent movies from the 1920s, I'm like, did people really laugh at this? So you're right. Humor is very much of its time and place and its culture. And even people of the same time and place might not share the same sense of humor. That being said, somehow it still works with if people are open to it. Somehow it's not necessarily because you've made a very witty joke or vice versa that we all understood and it's all its complexities. It's more that the sense that kind of we're laughing together. And I talk about a gentleman that I met in my practice in this essay, and he didn't speak English, so his daughter was translating for us, and nobody was making any kind of verbal jokes or humor. And this was the first time I was meeting him in consultation. And he just kept making funny faces at me the whole time I was talking. And I didn't know what to do. I was completely bamboozled by this interaction. And it actually ended up being sort of one of the funniest visits I'd had with a patient. Like by the end of it, I could barely get a sentence out. And I thought, this is absurd. Like, this is a very serious situation. This poor gentleman has, stage 4 lung cancer and brain metastases, but he just wouldn't let me be serious. So I think that humor can transcend cultural linguistic boundaries amazingly enough. Again, if the person was open to it, this person was almost determined that he was going to make me laugh. It was like he'd set out that by the end of this visit, he was going to make sure that we were having a good time. And I'm helpless against this. We're going to have a good time. I remember coming out of the room, the nurses I was working with, they were like, what was going on in that room? Is he doing well? I'm like, well, in a way, yes, he is doing well. At the end of this visit, we were all in a very good mood. But I'll sometimes use sign language, or I'll make some stab at French or whatever it is that the patient speaks. And then they just laugh at me, which is also fine, because they can kind of see that you've made yourself vulnerable by saying, it's okay if I can't speak your language. And they just smile and laugh with me. So it's not that it's a joke so much. It's more that they just feel comfortable with you. But you're right, it is more challenging. It's something I wouldn't usually do in such a situation unless I had gotten to know the patient and their family reasonably well.
Let's talk for a moment about wellness and joy in practice. What gives you the greatest joy in practice?
Undoubtedly, the people that I see and I work with. When you go into medicine and you train, we all train in academic settings, and I had excellent mentors and academic mentors. And the expectation, because you're trained by people who are good at that kind of work and succeeded, is that you might want to pursue that too. And it took me a while to realize that's not where I get most of my joy. Like, I like being involved with research, and I appreciate that people are doing that work, and I love applying that knowledge to my practice. But I get my joy out of actually seeing patients. That wasn't modeled a lot necessarily to us in the academic setting. It's taken me quite a long time to realize that it's okay to lean into that. If that's what I like about my practice and that's what I can bring to the interaction, then that's what I'm going to do. And I sort of looking back, it would have been nice to realize that it's okay. It's okay to be a clinician who really enjoys seeing patients and wants to do a lot of that. Again, different kinds of people become physicians, but a lot of the people we had as mentors, they had chosen an academic career because, not that they didn't like patients, they often did, but they really wanted to pursue the research aspect of it. And they would try and cut down on their clinical work and say, it's nice if you don't have 2 clinics, you can focus on the research. And I think to myself, but I like doing the clinics and I like seeing the patients. And it would be a shame to me if I didn't have that. It's not just the patients, but my colleagues as well, who also great fun to have around. And, the nurses we work with. Really, it's the interactions with people. I mean, of course, we get joy from all kinds of other things in oncology. It's good to see patients do well. It's wonderful to apply new knowledge and you have a breakthrough coming of immunotherapy to lung cancer, melanoma, or that sort of thing is fantastic. And it gives me joy too. But I have the feeling that when I retire at the end of my career, I'm going to look back and go, remember that interaction with that patient? I mean, even now when I think of sort of when I started in clinical settings as a medical student, I think it was my first or second patient I was assigned to look after was an elderly woman. She had a history of cirrhosis and she was admitted with hepatic encephalopathy. So she, and a fractured humerus after a fall. I didn't know what I was doing at all, but I was rounding every day. And I went to see her on the third day and I said, she was usually confused. And I said, how are you doing? She looked at her arm and she said, well, they call this bone the humerus, but I don't see anything particularly funny about it. I thought, oh, she's better. That's actually one of the earliest things I remember about seeing patients. Or when, the next year when I didn't realize I was going to pursue oncology and I was rotating through with an excellent oncologist, Dr. Ellen Werner at Sunnybrook, who does breast cancer. We were debriefing after clinic and she said, someday, Stacey, I'm going to publish the big book of breast cancer humor. And I thought, I wonder what that be in that book. And that's when I got this inkling that maybe oncology had just as much humor in it as every other part of medicine. And that proved to be true.
What was it, Stacey, that led you to bioethics? Tell us what you learned from your bioethics work.
I think it's because basically I'm a person least towards the humanities. And for me, bioethics is the application of philosophy and moral ethics to a clinical situation. And I think medicine, thankfully, has room for all kinds of people. Of course, you have to be good at different things to be a physician. But I always imagine myself when I went to school that after a class, you'd sit around a pub drinking beer and discuss, the great, the meaning of life. And I thought, this is my chance to pursue that. And I was hoping to I didn't think of it as like that I was going to do this because I was interested in humor and joy in oncology, although I obviously am. I was thinking that I would be able to make a difference in terms of resource allocation and priority setting, and I still want to pursue those things. Things often lead you down a side road. And so for bioethics for me, it has sort of reminded me kind of what I like about this work. And because I was surrounded by many people who are not doing that kind of work, who were surprised how much I liked it, it made me think very carefully about what is it that I like about this. So the bioethics degree, it's finally allowed me to be that person who sits around in pubs drinking beer, discussing Immanuel Kant and utilitarianism and whatever moral theories is of flavor that particular day.
What led you to write this particular story and put it in front of your medical oncology colleagues? Is it your wish to sort of let people sort of loosen up and be their authentic selves and find more joy in the clinic?
The most immediate impetus was I had an assignment for my degree and I thought I have to write something. But I'd been writing down these sort of snippets of things I found funny. Occasionally, I just write them down because they were interesting to me. And because we often relate stories, to people. And what did you do today? What was your day like? And because you tell these stories over and over, they develop some kind of oral mythical quality. You're like, here's what I remember that was funny that happened, and it might have been many years ago now. And I think I'd be thinking a long time about writing it down and sort of organizing it that way. And I guess this having to produce something as part of this degree program was an impetus for me, but I'd always wanted to do it. And I think the main thing was I wanted to make it clear to myself what it is I like about it. It's actually made it for me much more clear. It was a sort of nebulous thing that I like my work and what is it I like about it? And this is what I like. I like the joy I get from patient interactions. And then a secondary goal is I hope that other people, if they were to read this, they realize it's okay for us to have joy in our work as oncologists. And there is a lot of doom and gloom in the world and in our practices, but there's always a chink that lets the light in. There's always some humor in what we do. And so I hope that if other people can find that too, that they enjoy their practice and they last a long time and ultimately help patients through this difficult journey.
Are you somebody who likes to read stories? And if so, what stories have you read recently that you want to recommend to our listeners?
Oh, I am reading The Master and Margarita because 3 different people recommended this novel to me over the last 3 years. And when the third person did, I thought, that's it. Got to read it. It's a Russian novel from the 1930s. It was banned until I think the 60s or 70s. It's like a satire of Russian society in the 30s. And And actually what I like about it, I haven't finished it, I'm a third of the way through, is I think it's one of the so-called classic novels people tell me, but that's funny. A lot of the classic novels are kind of tragedies or romances, and this one is sort of absurd black humor in the face of a difficult situation, which I guess is related to oncology again. So this sort of oppressive, difficult society of the 1930s in the Soviet Union. How do you deal with that? With humor. So I'm quite enjoying it, actually. So I recommend that one.
Well, you're an amazing storyteller, and I really enjoyed our conversation. Is there any final message that you want to convey to our listeners?
If you have a chance to become an oncologist, you should do it. It's just the best career I can imagine.
Well, with your laughter and with that wonderful wisdom, let me say until next time to our listeners, thank you for listening to JCO's Cancer Stories, The Art of Oncology. Don't forget to give us a rating or review, and be sure to subscribe so you never miss an episode. You can find all of the ASCO shows at asco.org/podcast.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.